Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Science Medical Notes. So we have finished the topic of pharmacological therapy in hypertension. Let us now learn these topics which are mentioned here. They are resistant hypertension, hypertensive crisis, which includes urgency and emergency, and accelerated hypertension. Okay, let's begin with the name of Almighty. So what is resistant hypertension? It is defined as BP above target despite adherence to a rational 3-drug regimen including a diuretic. So BP is above the target on triple therapy. This triple therapy should include a diuretic. So this is nothing but diuretic resistance. Okay. So now what is the significance of this diuretic resistance? So what are the causes of diuretic resistance? Number one is pseudo resistance. Number two is true resistance. And this is the treatment. Okay, renal denervation therapy. This is the last modality to reduce resistant hypertension. Okay, so it can be pseudo resistance or it can be true resistance. So what is pseudo resistance? Inaccurate BP measurements. Example, cuff is too small, so the methodology of measurement of the BP may be incorrect. So that can be cause of pseudo resistance, means the BP measured is wrong. Okay, or it can be white coat effect, meaning because of clinic the BP is raised, or it can be as a result of non-adherence is the patient is not taking the medications properly. So these three can be the cause of this one, pseudo resistance. Pseudo means there is no resistance but it is looking like resistance. Okay, so BP measurement is not correct, or the patient is not adhered to the medications properly, or it can be a white coat effect. Okay, so these three are the causes of pseudo resistance. BP measurement, clinical BP is more than the home BP, that is nothing but white coat effect. And third one is the patient is not taking the medications properly, that is non-adherence. True resistance is, so true resistance is to true resistant hypertension. So you should exclude in these patients. Important is sodium intake. So patient may be taking increased sodium intake is the most common cause. Okay, so you should divide resistant hypertension into pseudo resistant or true resistance. Pseudo resistance possibilities, wrong method or equipment is not working properly, equipment used was not proper. Number two is it can be due to white coat effect, or it can be due to non adherence to the BP. Other causes which cause true resistance are: one is increased sodium intake. Okay, increased intake of sodium, this is one important cause of increase true resistance. Second important cause is uh, secondary hypertension, secondary causes of hypertension, secondary causes of hypertension. So these two are the causes of true hypertension, and these three are the causes of pseudo hypertension. Now if you merge 1 and 2, there are 5 causes of resistant hypertension, which you can divide into pseudo and true. In pseudo you have 3, and in true you have 2 things. Okay, so whenever you have a patient like this, you should evaluate like this. So what are the notes? So in pseudo resistance, adherence can be verified via supervised medication intake or urinary drug screening, which this is not done usually, but attenders of the patient should be asked whether the patient is taking the medication properly or not. Especially if the patient is elderly aged, they usually forget to take multiple doses, or a single they forgot to take the medicine, or take at wrong time, or take some other medicine instead of that. So that you should rule out by asking to the attenders. Okay, now in true resistance, now when you establish, so you should exclude one thing, you should exclude is two things, important things. When you get a patient with resistant, you should exclude non-adherence, and one more thing is secondary hypertension, secondary causes of hypertension. Once you have excluded the non-adherence and the secondary causes of hypertension, then meaning in all the causes, in total 5 causes are there, no, in total 5 causes, when you exclude all the causes, So here not mentioned one is secondary cause. So secondary cause should also be there. So when you exclude all the causes, then the fourth drug, which is the drug of choice in resistant hypertension, is spironolactone. You can give it in the dose of 25 to 50 mg once daily. Okay. Or if the patient develops gynecomastia, you can give eplerenone 25 to 50 mg OD. Okay. That's how you give. Now other drugs also you can give, which we have discussed in the guidelines. Okay, you can give beta blockers, you can give beta blockers, or you can give alpha blockers. Okay, or you can give centrally acting drugs, centrally acting. So these are the alternatives. Okay, but the drug of choice is spironolactone. Why the drug of choice is spironolactone in resistant hypertension? Because when you are giving AC inhibitor or ARB, it is thought that uh, so main cause is often linked to subclinical sodium retention. This is the main cause. But one more important thing is there is increased aldosterone in these patients with resistant hypertension. There is increased aldosterone in this patient. Although the receptor is blocked, but there will be increased renin in this patient. Okay, and there will be increased aldosterone in this patient. Okay, so this causes and increased angiotensinogen too. So because of negative feedback, these things will be increased. You are using ARB, this will be increased. If you are using AC inhibitor, then angiotensin 1 will be accumulated. So these things will cause resistant hypertension. So that's why to counter this aldosterone and to counter those uh, the effects of these hormones on the vessels, spironolactone is the drug of choice. Okay. Now a point comes when all the drugs fail. So in those patients, it is now recommended a therapy called as renal denervation. Okay, what you do? Ablation of renal sympathetic nerves using radio frequency or using ultrasound. Ablation of sympathetic nerves which are going to the kidney. So you ablate those things by using laser or ultrasound. Current guidelines. So this may be considered as an additive option in specialized centers for uncontrolled resistant hypertension. So one thing is resistant hypertension, one thing is uncontrolled resistant hypertension. So in specialized resistant hypertension, in specialized center, you can think of this renal denervation therapy. Okay. Okay, that's all about resistant hypertension. What is resistant hypertension? What are the causes? You can divide into pseudo resistance and true resistance. Pseudo resistance, incorrect methodology, or the equipment is wrong, or white coat effect, or non-adherence. And true resistance, increased sodium intake, or secondary causes of uh, hypertension. When once all excluded, spironolactone, alpha blocker, beta blocker, centrally acting, all these we can give, or aliscan also we can give. When but if the BP is not still to the target, then we can plan for renal denervation therapy. Okay, in specialized center. And now coming to the hypertensive crisis. So as I said, there are two things in hypertensive crisis. One is hypertensive emergency, one thing mentioned here, and the second one is here, it is hypertensive urgency. Okay, hypertensive urgency. So whenever the BP is more than, as mentioned here, so when you say it as hypertensive emergency, when the BP is increased, usually SBP more than 180 or diastolic BP more than 120 with target organ damage. How do you identify target organ damage? There are two methods. One is fundoscopy. Fundoscopy will do. Fundoscopy of eyes. So there you will see cotton wool spots. So grade 3 or grade 4 retinopathy you will see. Second thing is, or papilledema also you can see. Second thing is urine routine. Urine routine. In urine routine, you will identify hematuria. RBCs you will identify. RBCs. So by these two, RBCs and protein, you will see in urine routine. So these two will tell whether there is target organ damage or not. So this is when the patient looks asymptomatic, but still you should exclude target organ damage. Remember, when the BP is systolic one more than 180 or diastolic more than 120, patient may be looking asymptomatic even when the even if the patient is in hypertensive emergency. So in asymptomatic patients, how you will exclude emergency by doing this two, fundoscopy and urine routine. Okay, if these in these two, if it is normal, then it is considered as urgency, not emergency. Otherwise the patient will come with this much of BP along with symptoms. What can be the symptoms? So as we have discussed, target organ brain, the patient may have uh, encephalopathy, hypertensive encephalopathy, severe headache along with vomitings. With this much of BP, patient will come. Or patient may develop stroke, hypertensive or hemorrhagic stroke patient. That is one thing. Second is patient may have MI, myocardial infarction, or patient may be in heart failure, which is related to heart. Okay, that is one thing. Or patient may come with aortic dissection along with increased BP. Aortic dissection. So all these things are target organ damage. Or the patient, yes, these things are immediate pointers to the target organ damage. So headache along with excessive vomiting. Already it is given here. I'm not going on explaining. So what are the symptoms of target organ damage? So neurologic symptoms, encephalopathy symptoms, headache and vomiting will be there, or it can be stroke, hemorrhagic or ischemic. Papilloedema you will see in fundoscopy. Cardiac, you can have acute coronary syndrome or heart failure symptoms or aortic dissection. Renal, you can have proteinuria, hematuria, acute renal failure you can have. See, creatinine can be raised in this patient. That's why you should measure creatinine also, or it can be due to scleroderma renal crisis. Okay, the connective tissue disorder. So it is very much common, renal failure in scleroderma patient. Okay, then other thing is, one is neurologic, cardiac and renal. Other thing is hematologic or obstetric. Hematologic and obstetric. Hematologic, it is microangiopathic hemolytic anemia. What does that mean? Microangiopathic hemolytic anemia. So the blood vessels are occluded by small thrombuses. So because of this occlusion, when the RBCs pass through here, uh, there will be hemolysis of the RBCs. So that is nothing but microangiopathic, meaning small vessels are occluded by thrombus, and when the RBCs pass from there, they are getting hemolyzed. So that is causing microangiopathic hemolytic anemia. And pre-eclampsia and eclampsia, you know already the symptoms of pre-eclampsia. The patient may be having seizures. Okay, seizures, or patient can have edema along with edema plus protein in the urine is the diagnostic of edema plus protein along with increased BP, that is pointing towards preeclampsia. And when patient develops seizures, then it is called as eclampsia. Okay, hypertensive patient, sorry, pregnant patient. So pregnant patient coming with high BP along with edema plus protein in urine, that is preeclampsia. But coming with seizures with increased BP, that is eclampsia. Okay. So these can be the causes. So that means you should also. So what are the investigations you order in these patients? What are the investigations to exclude this hypertensive emergency? Okay, so investigation number one is fundoscopy, number one tool. Number two, you can have blood and urine investigations. Blood investigations, what you can do is you can do CBC if there is CBC, and if required peripheral smear hematologic. So you will have hemolyzed RBCs in that, and you will do some serum creatinine. Okay, and electrolytes also you will do electrolytes. So these are the basic, and TSH to rule out any hyper or hypothyroidism. You can do these things in patient with hypertensive to exclude you coming with this type of BP. Okay, these are the basic investigations, and baseline blood sugar also. Third, urine investigation. What you will do is the urine routine, and in that you will see for RBCs and proteinuria. Okay, so these are the investigations which you do to exclude hypertensive uh, patient coming with hypertensive emergency. May or may not they have may they have symptoms, then it is obvious, it is very much obvious that patient is having emergency. But if they come asymptomatic, then you need to do all these things: fundoscopy, blood investigations and urine investigations. So hematologic, it can be, or obstetric, hematologic, obstetric, microangiopathic hemolytic anemia, preeclampsia and eclampsia. So these are the symptoms and signs of target organ damage, and these are the investigations. What are the precipitants of emergency? Often progression of severe hypertension with acute complications. So patient may be having BP, but he may not be taking the BP medications. That's why suddenly the BP will shoot out and he will develop symptoms. symptoms. Okay, that is the cause. Now, how do you treat? How do you treat these patients? We will focus on this one. So I will take this here. Okay. So when in patients with aortic dissection, eclampsia, severe eclampsia, or pheochromocytoma. So I said no, you should exclude secondary causes also in the patient with hypertensive emergency. So along with that, you can measure serum meta-reference in these patients, and also you can exclude in these patients. You can do if you suspect USG renal Doppler, arterial Doppler also you can do if you suspect USG arterial Doppler. Okay. So first all those investigations plus these investigations, if you do this much, enough. Okay. So ultrasonography will tell whether the patient is having CKD also, because of which he is developing this hypertensive emergency. So if the patient is having aortic dissection, you will have symptoms. Okay, aortic dissection, eclampsia, severe pre-eclampsia, or pheochromocytoma. What is the target systolic BP? It is less than 140. Okay, but for aortic dissection, it is less than 120 in 1 hour. So what should be the target BP in these patients? So in aortic dissection, the target is very much strict. It should be less than 120 in 1 hour. You should bring the BP down to less than 120 in 1 hour in patients of aortic dissection. Central chest pain, tearing type of chest pain, which is radiating between the scapula and coming down, and BP will be falling. Patient's BP will be falling, and patient can have asymmetric pulses on both upper limbs, and BP can be asymmetric on both upper limbs. Or these are the things which help to diagnose. And if you do chest X-ray, mediastinum can be widened. It may not be widened; it can be widened. Okay, so these are the things by which we exclude this aortic dissection. Okay, troponins can be raised. Okay, so this is the target BP in aortic dissection, less than 120 in 1 hour in aortic dissection. But in pre-eclampsia, severe pre-eclampsia, whether it can be severe or not severe, and one more, pheochromocytoma. Pheochromocytoma. The target is less than 140 in 1 hour. Okay, that's one. So these are special things: aortic dissection, pre-eclampsia, pheochromocytoma. Okay, pheochromocytoma, very important to remember. Before uh, you should use before using beta blocking, alpha blocking should be done. So in order to avoid uh, excessive beta activity and rebound hypertension. So that is the important thing in pheochromocytoma. Okay, so these are special things which require target BP of 120 and 140 in 1 hour. Pregnant ladies, remember, you will see in OPDs coming with this. I have seen pregnant ladies developing a imminent eclampsia even after cesarean section. Okay, and also treated them. So other emergencies is not like that. For example, neurological emergency or cardiac emergency or renal emergency. Okay, in cardiac, exception is aortic dissection, and hematologic is preeclampsia and eclampsia, and one more is pheochromocytoma. Other emergencies decrease the BP by one fourth, 25% in 1 hour, then to 160 by 100 to 110 over 2 to 6 hour, then to normal over 1 to 2 days. So that is the thing, that is how you bring the BP down. So in other emergencies, may it be neurologic, may it be cardiac, except to aortic dissection, may it be renal. Okay, so what you do, you bring the BP 25% of the uh, BP down in the first hour. That is the number one thing. Then to 160 by 100 to 110 in next 2 to 6 hours. 160 by 100 to 110 in next 2 to 6 hours. Then to normal, meaning less than 130 by 80 in 1 to 2 days. That's how you step by step you will reduce the BP. And I have said, the in most of the emergencies, the drug of choice is labetalol, IV labetalol. What is the dosage? So you start giving 20 mg IV start. Bolus doses, if you give, you can give in terms of 20 mg. You give 20 mg, wait for 10 minutes. Again, if the target goal is not achieved, again you can give 20 mg. So like this, in bolus doses, you can give up to 300 mg of labetalol according to the book. But it is better to use labetalol in as a infusion. It is a safer side because you can easily titrate the dose of drug which is going into the body of the patient. So IV infusion is very much safer. Okay, so labetalol in most of the times. For some in meaning in aortic dissection, also in pre-eclampsia, eclampsia, not in pheochromocytoma, so that topic is different. In neurologic or cardiac or renal emergency, except to heart failure. Heart failure, the drug of choice is this one, nitrates. IV nitrates are the drug of choice. Okay, so usually aortic dissection in the first hour less than 120 is the target. In 1 hour you should bring the BP to less than 120 in aortic dissection, and in preeclampsia and eclampsia you should bring to less than 140 systolic in 1 hour. Other emergencies 25% in 1 hour, then 160 by 110 to 160 by 100 to 110 in 2 to 6 hours, and normal in 1 to 2 days. So that's the target. So there are some exceptions, I said, for everything, other emergencies. So one exception is ischemic stroke. So you should not bring the BP suddenly down. So some special thing is there for acute ischemic stroke. When there is acute ischemic stroke, less than or equal to 72 hours, means uh, if the stroke is less than within 3 days, stroke of less than 3 days. Okay, so the BP should be less than 185 to 1 by 110 before thrombolysis. Otherwise, the BP should be less than 220 by 120. Same as BP goal for intracranial hemorrhage. So one thing is important you note. So if you are not doing thrombolysis, you should remember important. No thrombolysis. Then the BP should be maintained in between 185 by 110 to 220 by 120. Okay, this is the range of the BP. Okay, don't make the BP fall below this one. So the BP should be more than 185 by 110 and less than 220 by 120. So this should be the BP by. So if you suddenly drop the BP in these patients, there is a risk of cerebral ischemia and increasing the size of uh, infarct due to edema. Okay, so to avoid that, you reduce the BP in stages. Okay, as explained in this in other emergencies. Like this, if you reduce, it is okay. But in these patients, ischemic stroke, you should take some time. Okay, in days you should take. Okay, so the BP should be maintained 120, 185 by 110, 220 by 120. Okay, if there is no thrombolysis. If you are doing thrombolysis, then the BP should be reduced to 180 by 110. Same thing applies for hemorrhagic stroke. Same thing applies for same BP goal as BP goal for intracranial hemorrhage. But I remember one guideline according to McMaster, if there is hemorrhagic stroke, BP should be brought to less than 160. McMaster says this, of which I remember. Okay. Okay. So when there is system stroke, so very important. So you should not reduce the BP very much. You should reduce very much, very gradually the BP. Okay. Particularly in ischemic stroke. Same as BP goal for intracranial hemorrhage. Okay. So what you should monitor in these patients? You should monitor the urine output, creatinine, mental status for tolerance. Okay. Urine output, creatinine, and mental status. You should monitor in these patients. Summarize, just to summarize. So what should be the target BP? So if acute aortic dissection, SBP should be brought to less than 120 in 1 hour, and pre-eclampsia or pheochromocytoma, SBP should be brought to less than 140 in 1 hour. Okay. Other emergencies except to the stroke. Okay. Other emergencies except to stroke, less 25% of the BP should be brought in 1 hour. Okay, then 160 by 100 by 100 to 110 should be brought in 2 to 6 hour. Then normal BP should be brought in 1 to sorry in 1 to 2 days. Okay. Okay, then the third one, in stroke patients, that is a special thing. Okay, special reduction of BP is needed in the stroke. We will learn detail about that in class of stroke. So, and the third thing, in ischemic as well as ischemic stroke, which is less than 3 days old, patient which is less than 3 days old. So BP should, if thrombolysis is done, then BP should be brought to 185 by 110. But if thrombolysis is not done, if it is not done, then the BP should be maintained in between 185 to 220 by 120. That means BP should be brought to less than 220 by 120. Okay, and but it should be maintained, and gradually it should be reduced in days to the normal BP. Same applies to the intracranial hemorrhage. Monitor urine output, creatinine. That's the summary. Okay, summary of treatment. That is hypertensive emergency. Okay, now coming to the hypertensive urgency. Hypertensive urgency. So I think we will finish this only. Accelerated hypertension will be in next class. Okay, so in hypertensive urgency, what you will have, so BP will be like this, but without target organ damage. Nothing. Fundoscopy will reveal nothing. CBCs, patient will not have any symptoms or signs. No secondary causes. Ultrasound, you do no renovascular cause. Nothing will be there. Okay. No CKD. Nothing. None will be there. Okay. So what is the cause? So cause is progression of essential hypertension plus non-compliance. Patient may not be taking the BP medication properly, especially clonidine, or diet changes. Patient may be taking excessive sodium, or non-compliance to the medication, or progression of the essential hypertension. So it can be either progression or non-adherence, or lifestyle interventions. These are the causes. That's one cause. Second, progression of renovascular disease. It means if the BP is due to secondary cause, then there can be progression of renovascular disease or acute glomerulonephritis or some connective tissue disorder like scleroderma or pre-eclampsia. So these are secondary causes which cause hypertension. So progression of the secondary causes increases the BP. Okay, same thing. Endocrine, second cause, pheochromocytoma, Cushing syndrome, and sympathomimetics. Patient may be taking cocaine, amphetamine, MAO inhibitors, tyramine rich foods. Okay, so what is the goal now? Treatment approach: return the BP to normal over hours to days. Reinstitute or intensify antihypertensive therapy. Oral options include labetalol, which should be given to 200 to 800 mg every 8th hourly, meaning usually it is given BD. Okay, 100 mg BD up to 200 mg BD you can give. Okay, but here it is up to 800. Okay, labetalol you will give, or you can give captopril. It is short acting drug, captopril, 12.5 to 100 mg, or you can give hydralazine 10 to 75 mg every 6th hourly. Okay, or you can give clonidine 0.2 mg loading dose, then 0.1 mg every hourly. So same thing, BP should be returned to normal over hours to days, similar to which we have discussed in hypertensive emergency. 25% reduction, then 160 by 100 to 110, then normal in 1 to 2 days. Same thing applies here. Okay, same thing applies. So drugs which you can use, you can intensify the drugs which are there now, or you can use other drugs like labetalol, captopril, hydralazine, clonidine. Okay, so that's hypertensive emergency. So the take home message here is to, so except for the main thing, 90% of the time you should reduce the BP very much gradually. You should not reduce the BP suddenly, except for some conditions like aortic dissection, pre-eclampsia, and pheochromocytoma, where you should reduce the BP very much suddenly, less than 120 in aortic dissection. Okay, and 140 systolic in pre-eclampsia. In 1 hour you should reduce that much BP. So otherwise, the take home message is, in whether it is urgency or emergency, gradually you should reduce the BP. One special thing is stroke patients. So where you should reduce the BP in days. Okay, days. BP should be maintained less than 220 by 120. Okay. If it is already less than 220 by 120, you should not touch the patient. Okay, you will reduce gradually, slowly, in days. Patient will be admitted for 5 days. If thrombolysis is planned, then bring down the BP to 180 by 185 by 110. Then you can thrombolyze the patient. Okay, that's about hypertensive emergency and emergency. So what you can watch, what drugs you can use for this. So the remember, for urgency you can use oral drugs as mentioned here. Labetalol you can use. Okay, labetalol is a good drug. Short acting drugs you should use in urgency. Short acting drugs. Labetalol is short acting. Clonidine is also short acting. Captopril is also short acting. Okay, because these are short acting, that's why these are recommended in urgency. These are all oral drugs. Then gradually you will remove these drugs and you will increase the dose of long acting, long taking drugs. Okay, that's how you reduce. You should not use long acting drugs in these patients. Okay, long acting drugs. Short acting drugs you should use. Okay, that's the point. And in emergency, always use IV drugs. In emergency, always use IV drugs. So IV drugs should be used in emergency. In emergency, oral in urgency, but in both you should use short acting drugs. Short acting drugs. Nicardipine is also one thing which is used. Okay, nicardipine orally and IV. So nicardipine is also short acting drug. You can use it for emergency and urgency. Okay, I think it is enough for today. We will discuss the later topics. Okay, thank you.